Good morning, guys. First and foremost, thank you guys for coming, especially on a beautiful day like today. I'm the EMIG director here at UTMB, and I'm so excited to introduce Dr. Fisher and Dr. Rumpf. We're starting with a great presentation today on why emergency medicine. Dr. Fisher joins us. She's the former Associate Chief for Operations at the Baylor College of Medicine. She's also the founding member of the Baylor College of Medicine Emergency Medicine Residency Training Program. She also served as the medical director at Ben Taub. She's also the founder of Mave RX, a leadership consultant firm. So it's going to be followed by Dr. Rumpf and myself. Dr. Rumpf is one of the faculty here at UTMB, as well as a clinical assistant professor at Ben Taub. So without further ado, let's get started with Dr. Fisher. Thank you.
Thank you, Dr. Kim. Wow, I was just talking to Greg. This is really exciting. First day of medical school for our first years. I mean, it hasn't been that long for us. Maybe it has. But I still remember how it felt. That's really awesome that you guys are out and you're already thinking about the best specialty out there, emergency medicine. We love our specialty. Emergency medicine rocks. I mean, I think when you stop for a moment, close your eyes and think about why you chose this path, which is not an easy path to follow, but when you stop and think about the path to medical school, everyone thinks about the doctor they want to be. Now close your eyes and think about the kind of medicine you want to practice. Do you see yourself standing in an operating room all day long? Do you see yourself, your friends or your parents calling saying, hey, I'm having some chest pain, and your reply is, well, I'm an orthopedist, I can't read the EKG. It's the kind of medicine that we all think about, the kind of physicians we all think about when we think about being doctors, because emergency medicine is birth, and we deliver babies, to death. It is so it's pediatrics, it's adults, it's geriatrics, it's trauma, it's medical, it's all the above. I mean, obstetrics, we do more of that than we hope to do, but we are skilled resuscitation specialists. Let me see, I'm going to usually work off slides, but I don't want to get ahead of myself. We are the resuscitation specialists. I mean, now, that's not to say that every patient we take care of is going to be dying when they enter into the emergency department, but honestly, those are the ones that really get us excited. I can field any phone call from any family member, any friend, anytime, any place, and I can give them guidance on what's going on, what their concerns are, what their symptoms are, because I have basic knowledge in all the specialties. Because it's our job as a resuscitation specialist, when we're stabilizing those patients, to anticipate the needs of the consultant that we're handing those patients off to. Now, whether that's surgery, obstetrics, whether that's the pediatrician as an outpatient follow-up, it's our job to know a little bit about everybody so that we can really get the information that they need taken care of in the emergency department. What really gets us excited, though, and I can tell you, I should pick on radiology because my husband's a radiologist, so it's kind of easy, because I still see that part of medicine from a close perspective. We make life-saving decisions in seconds, really with little or no input. You got to really be comfortable with being uncomfortable. It's like the creative side of medicine. I see something new that I haven't seen before. I do something new that I've never done before. Almost every single day I went to the Ben Taub, but now I'm in the community, so not quite as exciting, but still, what a variety. So when people say, you know, emergency medicine, jack of all trades, expert at none, I say bullshit. We're the resuscitation specialists. We are the people you want to call. You can't think of all the other specialties. What specialty can talk a little bit or can guide a patient no matter what their complaint? We're the kind of doctors I think everybody thought about becoming when they were going into medicine in the first place. Now along the way, they kind of figure out, like my husband, that life-saving decisions in seconds with little to no input, it doesn't suit his personality. So he, of course, chose radiology, where he gets to sit and contemplate in a very dark room, listening to his music, you know, what he sees or doesn't see. So it's not to say that the other specialties aren't fantastic. They are. I mean, radiologists are paid pretty well. That's a good thing. If that's your practice. But I think, why is emergency medicine special? Because more than any other specialty, we can talk about all the elements in life. And not only that, we can handle the sickest of the patients, whether it's acute injury or acute illness. There's no other specialty that can do that. So why emergency medicine? Because we can do everything, and it's just fun, and it's creative, and it's the fun part too is that you're really working with your staff very closely. No other specialty, no other area of medicine has a doctor standing there 24/7, 365. Anywhere else, when you take the patient out to PACU, anesthesiologist bops in, the surgeon will bop by. In emergency medicine, there's always a doctor. It's fun. So if you're like an extrovert and really, and I am an extreme extrovert, of course, if you really get jazzed up working with a team, this is your chance. You're going to lead the team. You're going to be there with your nurses, your techs. You're going to be constantly teaching. I say everybody's a teacher, everybody's a learner. Like I said, I learn something new every day. When I pick up the phone and call my consultant, and I say, I have this patient who's got this kind of fracture, and they're like, well, we're going to do this. And I'm like, oh, that's interesting. That's new. And they're like, yeah, the new research says X. So I'm learning as then I go and teach my patient or teach the nurses. This is the new splint we're going to put on because this has changed in practice. So where we get to be the leaders of the team, which I think is really fun, because the good thing about me is I'm bossy. The bad thing about me is I'm bossy. I'm bossy, but I get to lead and I get to follow. And I can tell you, the people that are attracted, the nurses, the techs, the whole group, people who are attracted to emergency medicine are going to be people just like you. I mean, I think it's a rockin' fun place to be. My favorite shift is a Ben Taub ER overnight, Saturday night. When we call it trolling for badness. We got the most highly skilled nurses, most highly skilled support staff, and man, we are ready to rock it. Bring on the badness, we're gonna handle it. We're gonna quickly decide what's going on with the patients and get them where they need to go. Oh, am I not flicking right? Tell me where I should flick. Oh, got it. So lifestyle. I'm not gonna tell you, I'm a mom, I have 2 kids, now 11 and 13. I'm not going to tell you that it's the easiest lifestyle. It's not, because it is weekends, nights, holidays for the rest of your life. So parents, get ready. You're going to spend half your Christmases away from your kids. You're going to spend half your Thanksgivings away from your family. But I'm going to tell you, when I'm off, I'm off. And when you get into administrative roles, leadership positions, you start to lose some of that flexibility. But other than that, I mean, I take a week, 7 to 10 days off every month. I mean, now I work 8 24-hour shifts. So I'm off every other day of the month. I make my own schedule, so I fix it around my vacation and my kid's schedule. So great pay, great hours, if it's for you. Now my husband is an outpatient radiologist. I'm gonna pick on him again. He doesn't like to do nights, weekends, holidays. So he works Monday through Friday. To me, that's the grind. I would go crazy if I had Monday through Friday, 8 to 5. But it fits him, so there's always the alternatives. And specialization, wow. You want to do it? We can do it in emergency medicine. Whether it's operations administration, which of course is my favorite, ultrasound. You can do a dual training, EM, IM. Dr. Rumpf will tell you, he's going to talk to you about his practice on the wards as an internist as well, which I think emergency medicine probably helps. Your specialty trained emergency medicine helps when you're rounding on the wards with your internal medicine team. But research, global health, I know it's so fun, especially the newer generation. You guys love to talk about going and working abroad, which I love to travel, but I don't want to go work when I travel. But global health has been a great specialty. So anything you can, and here you guys have the fellowship in aerospace with NASA. I mean, no other specialty has a family. What am I forgetting, guys? Sports medicine, critical care. Oh yeah, I gotta forget critical care. I mean, there's just anything you want to do, there's a fellowship for it in emergency medicine. So you can really specialize, pediatrics, there's just so many different things you can do. And it gives you really the best opportunity, I think, at life balance, wellness. I hope I have a few minutes towards the end, because I really want to talk more about, I would like to add some things about leadership development and those things that kind of go in with that. But when we think about wellness, we think about starting with the end in mind. It's so important to take care of yourself so that you can be happy. Happy doctor equals happy staff equals happy patients equals great Press-Ganey scores, which means happy administration and hopefully happy paycheck. So wellness, it's important. I went to the gym for 60 minutes today. It's important, and I think emergency medicine really lends itself to work-life balance. You know, you got to be in shape because you physically are running a lot of the time, especially when you have some really sick patients. So I'm not sure if it's good. Do y'all want to say a few words? Because I always bring a case, because I get that a lot when I lecture. What's the craziest thing you've ever seen? And I'm sure Dr. Rumpf knows this case. But do you guys want to say, what have I left out about our specialty that's so awesome?
Do you guys want to come up?
Come on. What's your favorite thing about being an emergency physician?
What's up? Yeah, put me on the spot here. All right.
Off the top of your head, what do you love about emergency medicine?
That's a tough one because I like a lot of different aspects, and because I'm dual boarded, emergency medicine, internal medicine, I probably like things maybe a little bit different, but the resuscitations, the sick patient that's dying in front of me is honestly my favorite thing. Like walking around the ER going, okay, what are we doing? We got sniffles in room 1, we've got sniffles in room 2, we've got toe pain in room 3, we've got hemorrhoid in room 4, we've got butt pus in room 5. Oh, somebody's coming in that's dead? Forget all these other people, let's go take care of them. That's, the first 5 rooms, that's the majority of the patients that come in, are pretty minor stuff. People that perceive them as emergencies, okay, so part of your job is to realize it's an emergency to them, maybe not to me. I don't understand why they come in to see me, but that's okay.
Because they get paid. We get paid.
Yeah, we get paid to see them, and our job is also to give back to them, to educate them and let them know this is how you handle this stuff. But the excitement of what can I do in the resuscitation and how can I fix that? I think my second favorite thing is probably dislocating or relocating dislocated joints, because it's just satisfying.
I say the same thing. You hear the clunk and it's back in, the patient's well, they get to go home. It's very satisfying.
Or there's no pulse.
Dr. Kim, what's your favorite?
Putting me on the spot right here. I mean, there's really 3 aspects of it that I enjoy the most. One, and I share with both of these guys also, is the critical aspect of emergency medicine. I mean, there's very few fields where, whether it's a pediatric code, an adult code, whatever it is, that really there's no better physician to be leading that than an emergency physician. The second aspect that I enjoy a lot about emergency medicine that you start seeing over the past years as kind of a change in paradigm with the different fields that everyone's pursuing is lifestyle. So as far as lifestyle goes, just like Dr. Fisher was talking about, you can control your schedule to some degree, and you're able to take advantage of that without having to be on call. You can move around the country if you'd like. Don't have to establish a patient base and have them follow you. In fact, you don't want that patient base unless you're that type of doc. And then the final aspect for me is the academics, which is why we're all here, is just the ability to be interactive and be able to teach on a daily aspect. And although that's present in some of the other fields, I find, especially with emergency medicine, it can be very dynamic.
Did y'all get that? He was put on the spot. See, emergency physicians were comfortable being uncomfortable. Put him on the spot. He just stated 3 reasons that he loves emergency medicine. He's perfect for the job. That's what we do. Think on our feet. So I'm going to keep chatting. Y'all keep filling in. And I'm going to show you a really fun, exciting case. And then we'll leave it to Rama to instruct us further. It won't be but just a few minutes. So I'm in the emergency department one day about 2 p.m. And we get a call from EMS saying that there's a guy who fell off a 2nd floor roof and is coming in with a crowbar in his head. And we're all like, yeah, it's a Bentop. I mean, you know, and it's so funny. I believe my mantra, y'all can correct me if I'm wrong, I believe 50% of what I'm told and only 75% of what I see. Because even when I see it, often it's like, what? How can that be? That just defies logic. That should be our special, defies logic. We see that a lot. So we go into the room in the trauma bay, we're setting up, and Ben Taub, if we think the patient, so we're thinking in our minds, this patient's either DOA, or he's dead on arrival, I'm sorry. I forgot we have some brand new, shiny faces. Dead on arrival, or he's just got a little abrasion across the side of his forehead. You know, I mean, when are you gonna get a patient with a crowbar through the head? So, but we go in because we're, very efficient. That's emergency medicine, efficient care. We put the body bag underneath, we put the body bag on the stretcher and put the sheet over the top. So if he is DOA, we just fold him up, push him to the morgue so that we can move our next patient in. Efficient care. So we're sitting there, and we have the trauma team is down with us, and there's always a lot of hype and excitement when you get a trauma. Truth is, and we love it, but the truth is trauma is pretty algorithm, basic stuff. If you really want high-level thinking, you can ask Dr. Rumpf. You do internal medicine. The medical critical care stuff that we do, much higher level. But we all get excited about trauma. So this guy's rolling in, and we hear someone coming down the hall, and there's just this blah, 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 blah. And I'm like, okay, we're just waiting. And this is coming towards us. This person is talking. And I'm like, okay. So this is what rolls in. And he speaks Spanish only, and where I can speak Spanish, medical Spanish, I'm like, we're all like looking at this. I'm like, okay, someone, what is he saying? And he says, the nurse says, Dr. Fisher, he wants to know how you're going to take out the crowbar. I'm like, okay, and as a good emergency physician, comfortable with being uncomfortable, I say, can you please tell the patient that I'm Dr. Fisher, I'm his ER doctor, and I'm going to be coordinating his care today. So literally, as it progresses, we get neurosurgery and anesthesia, oral maxillofacial surgeons, and the trauma surgeons are with us, and we're all kind of standing around trying to figure out what we're going to do, because you saw the back of his head. You can't lay him flat to intubate him. He's sitting upright. So he ended up, and you can see these are the pictures actually from the OR. We were too busy. He ended up with a nasal intubation in the OR, not down in the emergency department. He ended up with a nasal intubation, and they just cut out the front of the skull in the front, and the piece of skull in the back, and pulled the crowbar out. It had gone through the corpus callosum. This guy is completely neurologically intact. Just crazy. We do at Ben Taub or Harris Health every year, we do a Circle of Survivor. This guy's come back the last 2 years to thank us for saving his life. But another part of emergency medicine, I think, that really makes me, that I like, that's rewarding, we don't get the continuity of care. I think you'll find most of us don't really want to, tweak blood pressure medicine or tweak diabetic medication. It's not really for us. But that continuity for us is going in and talking to the family. When I had the opportunity to go talk to this guy's family, first I wanted to prepare them for what they were about to see, and also prepare them for the fact that although he's awake, neurologically intact and talking, he might not be that way when he comes out of the OR. Because there's a lot of bleeding. Of course, it's going to happen when they perform surgery on a guy that's sick. So the conversation was whether, normally our conversations are, well, the patient is coded at home, and remember I always say the ambulance people, because you want to talk in, understandable words when you're talking to family, and they don't know paramedic, EMT. The ambulance man put in a breathing tube and was pumping on his chest, and when we got him here, we continue to do that because his heart stopped beating, and then you have to say the patient is dead. Usually it's the patient's not awake and talking, it's a bad outcome, it's a bad prognosis. This was, the patient's awake, alert, and talking, it could still be a bad prognosis. Go in and say all the things you want to say to this family member. And like I said, he was intubated in the OR. We kept him downstairs for another 10 minutes so he could spend time talking to the family and friends that had gathered, because we weren't sure what that outcome was going to be. But fortunately for us, it was a great outcome. It's a top 5 story for me. If you'd like to see there's another shot. And I love I just think Baylor College of Medicine is awesome. The neurosurgery group there does a ton of research on traumatic injury, and actually Dr. Gopinath and I were on Untold Stories of the ER. So if you go to Untold Stories of the ER and click Crowbar, you'll get the whole story. It was really fun. I wish every day could be a Crowbar kind of day, but it's not always that exciting. But there's usually something there that keeps your blood pumping, keeps you running around, fun stuff. So that's why emergency medicine. Take questions? Questions, thoughts, feedback? What do you guys think? Do I dare? Yes. They removed the skull from the front, removed the skull, and they had to chisel off because both ends, one was round and one was chiseled off and pulled it out with the round end. Yes. Now I do. At Ben Taub, no. In a busy emergency department, no. Now I switched gears, and this is what's fun about emergency medicine too. In my 20s, like most of you, I focused on my education. In my 30s, I focused on my professional career development and leaving, what it was going to be that I was going to do. In my 40s, I'm raising my 2 kids. So I can hopefully successfully launch them into the world and regain my life and retire one day. Who has kids in here? Y'all get it? Nobody has kids. Oh, just the old people. One day you guys will get it. But now at Ben Taub, we did 8s, 9s, 10s, 12s, everything. Even 6s. Some people would split their 12-hour shifts. But now I went from running the busiest ER in the 3rd largest city to the slowest ER in the 3rd largest city. And that's a nice change, nice break, and I get to focus on this kind of stuff that I really enjoy doing, the leadership development. But great question. Yes?
You said when you're off. But are there ever any times when they would call you in? Or is it really when you're not at the hospital, you're not going to get called in for any reason whatsoever?
Clinically speaking, that is true. Now you might get a call from your buddy that their mother died or their kid is sick. Somebody might want you to come in and cover for them. But when you're not on clinically, you're not responsible for any clinical duties. Now, if you're a slow charter, you might have to catch up on documentation, but it won't be we don't know what pagers are. We don't carry, I don't think anybody does anymore. Now, what do you have, like a smartphone text or whatever? But no, there's nothing from a clinical standpoint when you're emergency medicine. Now, don't get me wrong, an 8-hour shift for an emergency physician is much different than like an 8-hour day on wards, right, Greg? An 8-hour day on wards, they sit around and they talk, they have coffee, and they round on their patients, and they go talk, and then they go have lunch, and then they come back and they talk, and then they talk some more. For us, it's 8 hours, a run. In a busy emergency department, you are, in a busy, the national average is 2.4 patients per hour. That's why these patients that come into the emergency department for whatever reason, whether they're uninsured, underinsured, or not sure about whether they need to be there, we're glad to have them because that kind of helps us with our patients per hour, and so we can get paid and get money, and give us a break. Imagine 2.5 sick patients an hour would be a lot. Yes?
What changes do you see coming for emergency medicine in the next 5 to 10 years?
I think, and definitely a question for these guys as well, and I don't get offended, I'm really informal, so if you guys got to go, don't be shy, just come on out. I know, I remember what it used to be like a long time ago. For emergency medicine, I think we're going to be the point of entry for healthcare. Are we done in 30 minutes, or?
We're going to be done in the next couple of minutes.
Okay.
Yeah.
So in emergency medicine, I think we're going to be the point of entry. I think hospitals are going to be ICU. Because you can see they're minimizing, and we have access to all the care to take care of people. So because we're the one-stop shop, I think we're going to only become busier. Yes. And if y'all go ahead. That's a lecture, and the question was, is there benefits of being part of whether you're employed by a hospital or a private group or like a large contract management group? That's like that's another lecture, honestly. But that's an excellent question, and that's the good thing about emergency medicine. You can work in any of those, in any of those facilities, in those different, you have different job opportunities. Okay, sorry.
Thank you guys for coming. I just want to thank Dr. Fisher, Dr. Kim, and Dr. Brum for taking time out of their day to come here and talk to us.